So I'm super excited actually to talk about what is new in medications in the Parkinson's world, because this has been a super exciting year for us as we've all been waiting for some breakthroughs to happen. When I looked back at my talk from last year, I did a lot of teasing of things in the pipeline, and this year I get to tell you about them because they are out and they're available. So it's just super exciting for us and for many of my patients. Oh, I didn't even verify which clicker. Okay, all right, so I like to put this up here whenever I talk about the Parkinson's medications, because as you can see, this is a list of potential drugs that we can use to help manage symptoms with Parkinson's disease. All of the ones in red are a version of levodopa. So there's not just one version of levodopa. All of those ones in red are different ways that we can deliver levodopa to you. The rest of the medications are what we call adjunctive medications that we give along with, or sometimes on their own, but we will pair them with the medications that have levodopa in them. So some of them are dopamine agonists, which means they kind of act like dopamine. Some of them are treating very specific things, like amantadine and gocovri and Osmolex all treat dyskinesias. We've got medications that can help levodopa stay in your system longer. And then we've also got other things that symptomatically we treat things like Noreons treats hallucinations. So these are all things that we have in our toolkit that we use to treat Parkinson's. So I'm sure many of you recognize a lot of the names up there. So how do we choose? How do we know what medications to offer you? I think the most important thing that I tell everybody when I'm talking about treatment for this is you've got to find yourself a movement disorder specialist. And I think that many of you in here probably do have a movement disorder specialist, just because I know the crowd. But if you don't, or if you know people with Parkinson's disease that are being treated and they're not treated by a specialist, we are the ones that are on kind of the forefront of what is coming out. So a lot of times people may be treated by a general neurologist, which is perfectly fine because I'm aware that access to specialists is not the easiest thing in the United States. But they might not know about something like Vyalev, which is what I'm going to talk about in a little bit, and they might not realize that this is available now to Medicare and that we can get this going for you. So having a movement disorder specialist is super important. The other thing about having a specialist is that when you're telling us what's going on when we're in a visit with you, we're asking you, well, how are things going? How are your medications lasting? And as you're telling us, we're like going through this insane algorithm of what medications might be able to help you with that and what ones we know we don't want to use. So we're already kind of screening you for what you're on, what does your insurance cover, what can we offer you, what can help, close those windows. And so that's something, because that's all we do all day long, we're thinking of this for you. So I think that's a super important place to start when you're trying to, optimize your regimen. When you meet with a movement disorder specialist, you're going to have a consult with the doctor, and they're going to go over everything from your medical history, how long you've had Parkinson's, what medications you're taking, and all of those important things. In Parkinson's especially, the medication prescribing is an art just as much as it is a science. Knowing which drugs to pick for your patient is something that just comes with experience, and knowing what the potential side effects you definitely don't want to introduce to that patient is also important. So being able to trust your doctor or your nurse practitioner or your physician's assistant and know that they're listening and that they know what your goals are is super important. And then also the very important thing is, why are they suggesting this medicine? So you're allowed to ask these questions. Why are you choosing this one for me instead of this one? And even if you have no idea what other options are out there, just understanding why your doctor's choosing this medication for you is very important. This is supposed to be dramatic. So in 2025, as a provider, and hopefully also for all of you as patients, Parkinson's treatment feels like the new frontier. I was hoping that you guys would know who this was. Most of you, right? Okay. I was trying to go for my audience here. So it's like the new frontier. We have new things to choose from, and it's very exciting. So in 2025 alone, we have had the introduction of 4 new FDA-approved Parkinson's treatment therapies, which I don't remember in the last almost 10 years of doing this that we had this much happen in 1 year. So I mean, it's very exciting. So the first one that I'm going to talk about is Crexont, which is a new and improved version of Rytary, which was a new and improved version of Sinemet, and so now we've just further improved that. So I'm going to talk about that. You guys already sat through and listened about adaptive DBS, which is, you know, a much better version of what we've already had available, so it's allowing the DBS to adapt to you. And then we also have the two new things that I'm very excited about and I'm going to share with you, and that's our subcutaneous infusion therapies. And that's called, one of them is called Vyalev, and the other one is called Anapgo. So I'm going to talk about Crexont, Vyalev, and Anapgo because those are the 3 new medications, and that's what I'm supposed to talk about. So the first one is Crexont. So this is an extended release version of carbidopa-levodopa. So all the little yellow pills you all take, some of you call it carbilupa, levodopa, whatever, that is our main drug that we use for Parkinson's. Well, it doesn't last very long. If you listen to Dr. Walter's talk, he talked about how it can sometimes only last 90 minutes and then it gets recycled. So the big goal has always been, how can we get that drug to last longer in your body? So extended release carbidopa-levodopa first came out with Rytary, so you'll see those 3 listed there. So the first one, immediate release, is the little yellow tablets. That's all of our best friends. The next one, the extended release, is Rytary. So that was the first one on the market in like about 2016. And then now you'll see Crexont is the newest one. And so the difference between the 3 are all laid out right there on that picture. So Rytary, when it came out, had both immediate release and then they also had extended release components. So you would get a little bit of your meds right away, and then you would get the rest of your meds a little bit slower throughout that interval of medications. So Crexont is from the same company, it's just more improved because now it has this, they developed what's called a mucoadhesive polymer, and what that does is it takes the parts of the medication and it allows it to stick onto the sides of the small intestine for much longer. So some patients, depending on how much levodopa you're on, you can take this medication twice a day. There's patients that are usually taking a lot more medication tend to have to take it 3 times a day. But you're not supposed to have to take it more than 3 times a day because it's supposed to be able to stay in your system for longer. I probably could have advanced the slide. So this kind of just summarizes what I just told you. So I did put up a little bit of like the data slides I'm going to show you. And this is because 1, I like to try to explain to people how this stuff works in your system. And 2, I know there's a large number of engineers that we treat and you like numbers. So I was going to show that to you too. So here's the perfect example of the difference between the 3. So you can see that bottom line, the gray one, is the immediate release carbidopa-levodopa. Across the bottom is the time in hours, and across the top is the amount of the medication in your system. So when you take the medication, that's what 0 is, it spikes in the bloodstream really quickly. So that's the gray one, you see levodopa shoots straight up, so does Rytary and so does Crexont because those 2 drugs also have immediate release in them. But as you see, the first one to drop off, and rather quickly it drops off, is the Sinemet, the immediate release. The second one in the middle is Rytary, so you can see that we made quite an improvement when we came out with Rytary, but again, it falls off as well. And then the last one is Crexont, and you see that it peaks the highest and it drops the slowest. So this is why it allows you to not have to take it as often. And so just some of those little, factoids over there, that Crexont is sustained for 4 to 8 hours, Rytary is sustained for 3.9 hours, IR is sustained for 1.9 hours. So you get the extra time back in your day on time with the extended release. All right, so that was the little bit about Crexont, and again, like I said, that is just another version of the same medication that we've had for all these years. And for a long time at the beginning of my career, I thought that's all that's all it felt like we came out with, was a new version of something we already had. Well, we now have a new version of something we've always had, but this one is delivered completely differently. So the new star is how I feel. Of course I feel that because I'm the one that likes to do this stuff a lot, is the subcutaneous infusion therapies. So if anybody in here has diabetes or knows somebody with diabetes, we know that the field of diabetes has changed with the continuous infusion of insulin. And you see, tiny children with type 1 diabetes with the insulin pumps, and they have a little monitor on them, and they can do it themselves. It's that easy. And that's where diabetes moved, because they saw that continuously treating or continuously giving the insulin to the diabetic throughout the day was the optimal way to treat that. So this also was kind of covered by Dr. Walter's talk, but it talks about the therapeutic window, okay? And as we know in Parkinson's, the longer you have Parkinson's disease, the smaller the window of good on time is with your medications. So if you think about, depending on how long you've had Parkinson's, way back at the beginning, and you took levodopa, and it was like the miracle drug, and you were like, I feel amazing. That can still happen, but it's for smaller windows of the day as you progress with Parkinson's disease. So this shows you kind of broken up into years. That white area in the middle is the therapeutic window. That's you feeling good. Your meds work, you feel good, you can get done what you want to do. The purple above is if we overshoot that window and now we've got dyskinesias. Below is you can't move. So as you see, once you've had the disease for 7 or more years, your window's really starting to get kind of small, and there's a lot more time either feeling off or feeling like you're moving too much. This red line is what we want to do. So all of these researchers, like the researchers we just had up here, we're trying to figure out ways that we can make your day slice right down the middle of that therapeutic window. And so when we look at what we need to try to do, instead of doing something that's called a pulsatile distribution, which is give meds, give meds, give meds at pulses throughout the day, we wanted to figure out how can we continuously deliver this. So this is the first pump that I'm going to talk about. This is called a NAPGO. It's supposed to be like where you can like get up and go once you put it on. So you put it on and you're up and go. I think that's how that name was supposed to come about. So this is not levodopa, but it's subcutaneous apomorphine. So apomorphine is not related to morphine, and this is not a narcotic. So I will just say that first, even though the name is a little suggestive of something like that. But what it is a dopamine agonist. So anybody that's ever taken pramipexole, ropinirole, rotigotine, that is the same drug class. Well, those drugs sometimes will have side effects when you take them orally, but when you give them subcutaneously, their side effects are very different and much less. So people that can't tolerate dopamine agonists orally actually can tolerate this pump much better. So what does it do? It is another one of our adjuncts that we can add to levodopa. So you will not stop your levodopa pills, but you could potentially reduce them with this pump. You wear it for 16 hours a day, and it helps smooth out your day. So your ups and your downs aren't so drastic, and you feel on a little bit more. So in the studies, it showed that 2.6 hours less daily off time, plus 2.8 hours more of good on time each day for the patients that were wearing this pump. 1/3 of patients on a NAPGO were able to stop taking at least one of their add-on medications. Some of them could stop even more. So one of the goals for this pump is not to stop your carbidopa, levodopa, but what it is to make you feel better and potentially reduce some of your other medications. The goal is always to give you more time in your day back, where you're feeling good and you can function the way you want to. This is for the engineers again, or mathematicians. I know there's a lot of you at some point in my practice, so I wanted to put this up for you, but this is just showing how from baseline then to, I think it was 12 weeks, I think. It's very small, I can't see it from this far away. But the big numbers, 15% mean reduction in levodopa dose from baseline. Versus a 5% with placebo. So we saw that you didn't require as much medication when you were taking this therapy in the clinical trial, and 33% of patients discontinued at least one of their medications. So there's definitely an improvement in how people are feeling and what their pill burden is once they are on this pump. And let me tell you, this pump is easy to do, okay? I worked with Duopa in the past. Duopa had to have a surgically placed peg tube to be able to deliver the medication directly into the intestines. This is completely non-surgical. If we put this through, we get it approved with your insurance, nurses come to the house and they teach you how to put this on. It's very easy. Almost all of my patients are like, oh man, after the first couple times, this isn't bad at all. If you don't like it, don't do it. It's reversible. You don't have to have a surgical procedure to do this. So this is just a little graphic of what it looks like. For this one specifically, they give you a little vial of drugs, you snap it into the pump, you have a cannula that goes just under the skin and delivers the medication, and this pump you'll wear 16 hours a day or just however long you're awake. So how do I get my hands on this pump? So one of the things you need to do is ask your doctor about this. So at the Cleveland Clinic, we have the access to the ANAPGO pump. You have to have your insurance approved. This one does go through Part D of your Medicare, but it can get approved. Every plan is a little bit different on the speed at which it gets approved, but it's Medicare approved for your Part D plan, which is your pharmacy benefits. So talk to your doctor, let them know that you're interested in. Ask them, do you think I'm a good candidate for this? Is this something that I think, that you think that would really help me? If they think so, they'll submit this enrollment form. Once it gets approved, the Circle of Care, which is a nursing program, comes to the house and will initiate this pump. So you're initiating it at home with a nurse that knows how to do it. And then after you get that started, then you come in to see your doctor again, and then they're gonna discuss titrating other medications. But wait, there's more. This one is the levodopa pump. So this is the subcutaneous levodopa pump. It's the only one on the market, and it is the first one that has come out with the ability to get levodopa in liquid form to be able to be given subcutaneously. So the reason we couldn't do this in the past was because we didn't know how to get this medication to be water soluble. So they were able to find, and because of research, we were able to find a way to make this water soluble. And now we can infuse levodopa under the skin 24 hours a day. So no more waking up in the off state where you can't even start moving for the first hour of your day or 2 hours of your day until you take your medications. Since this is worn all throughout the night, you're always more in the on state. So it's the same exact active ingredient of the medications you take with your levodopa. Sinemet, Crexont, Rytari, it's the same active ingredient. It is spelled a little bit differently. It says fos-carbidopa and fos-levodopa, and that's because it has a phosphate chain added to it, which allows it to be given this way. So that's what the science found. This replaces all of your oral levodopa therapies. So those of you out there taking, Sinemet 5 times a day, living by the alarm, that goes away with this pump. You don't have to keep doing it. And this provides superior on time compared to levodopa. And what we mean by that is way less dyskinesias, consistent on time throughout the day, and you can wear it for 24 hours. So this is some of the clinical trial data. It gave almost 3 extra hours of good on time with no dyskinesias per day to patients in the trial. And yeah, this is really small, 0.97 hours compared to oral levodopa. So, what happened in the study was they compared it head-to-head with oral levodopa, and in the optimization phase, the patients that were taking oral Sinemet were optimized. And so what that means is they may not have been optimized before the clinical trial. So when they came to the study, they got their medications working even better. And so then they actually found, well, hey, when my meds are working better, I actually get a whole nother hour. But when compared to the pump, they got almost 3 extra hours of on time. So you must be asking, but Shannon, there must be side effects, right? So the side effects are exactly the same as the side effects you would have from levodopa, okay? It's the same drug. But something that's added when you're doing something under the skin is skin changes. So skin changes is something that we're very aware of, and we work really hard to make sure that you don't have skin issues with this pump. And I'm gonna show you a picture and get into that a little bit more in just a second. So this is the data on the skin. So some people did experience skin reactions, and a very small amount of people had an infection, but using great maintenance of that skin site prevents a lot of this. So the skin things that happen, which I think here we go. This is a picture of the infusion site reaction. So this is one of my patients who, if you see on the picture that's on the right side without the cannula, you see there's like a kind of a bump down at the bottom. That's a skin nodule. And that is skin that has been infusing quite a bit, and so it kind of gets a little hard nodule on it. All these little other red areas around it are just kind of like redness. None of this is an infection, and none of this is something that's overly painful. And my patient wanted me to take a picture of his stomach, and he wanted me to share it with people and say, yeah, my stomach gets sometimes these little bumps and stuff, or it's a little red, but I could care less because this pump makes me feel amazing. So the skin things are not that big of a deal, but it's just something we have to let you know about. And then myself and my colleagues that will start these pumps as well, we help you manage this stuff. We help you come up with ways to make sure that you don't have skin irritation. And lately, my last 10 or so patients haven't even experienced a skin problem. So we're getting better the more we're doing this. So this is the APRN-CNP side effect data. That might be a little out of order, but that's okay. So this is talking about the infusion site nodule formation, and then also hallucinations. So this is important because a lot of times with an oral medication, the oral dopamine agonists, we want to make sure we avoid these side effects because they can be severe, as what Emma talked about. But with this pump, we're seeing a lot less of the side effects we see with oral medications. But again, I'm sorry, that is the APRN-CNP, and I think it was just a little bit out of order. Okay, so this is the good stuff. This is what you guys want to see. So I wanted to make sure I got to this. So I have a wonderful patient that's here with me today, and this is the testimony. Oh, his testimony questions are missing, but that's okay. I can tell you about him because I know about him. So this patient of mine, his name is Jim, and I've been lucky to be one of his care providers for probably 4 years now, 4 or 5 years. He did have DBS, so you guys have learned all about DBS, which did very good things for his tremors, but he had lots of motor fluctuations, meaning on and off and on and off, to the point, and severe dyskinesias, to the point where there was a very little time of the day where he wasn't moving in one way or another, dyskinetic or tremor. And so these are the patients that I really like trying to convince to do pumps, because if I can't find that window where you're on and off and you just flip from on to off super quick, it's very difficult to manage that. So I brought it up to Jim, convinced him, hey, let's try it. And if you hate it, just stop it. You don't have to do it. And so luckily, Jim decided to try the pump and has done fabulously. And really, really, I just can't, I'm so happy with the benefit that he's gotten. So he's agreed to come and share just a little bit about his experience with his wife, Stacy. They can both come up. Because as you all know out there with your care partners, this disease affects both of you. It affects the whole family, right? So, so here's Jim. I would like to point out that he's, well, other than he's walking, he's not moving. Yeah, so sit down, please. So I did have a slide of questions, so I'm just going to go off the cuff here because it's not up here. But one of the things, Jim, I want you to tell me, oh, he's supposed to have a microphone, guys. Do we have a microphone? Ah, does this work? Hello? Okay, perfect. All right, so I'll give this to you. Okay, so one of the questions that I wanted you to tell the people out here is, were you scared to start this? What was your hesitation? How did you feel about the idea?
Yeah, it was a little intimidating when I started researching, and every single day you got to put all these components together, and you got to take a vial, fill up the medication, put a cannula, and I'm thinking, that's a lot of work. But Shannon kept pushing, and
Gently,
and finally we said, okay, we're going to give it a shot. And AbbVie sent a nurse ambassador to our house, Leslie, and she said, I'm going to be here until you guys feel comfortable. So we started going through the process. And they've got it very well organized. And she took something that I was thinking is going to be very complex. She made it very simple. And we went over it and over it. Even my son's there saying, hey, can I give it a try? And we're like, sure. So she did not leave until we felt very confident and we felt very comfortable with it. So
Great.
that was great.
Yeah. One thing, I know we're running a little short on time, but I really want to know, Jim, how hard is it to sleep with the pump on? Everyone asks me that.
It's a little unusual. During the day, it's like wearing a fanny pack, or you just got a Walkman on your belt or something like that. It's a little bulky, but at night, it took a little bit of getting used to, because I sleep on my left side, then my right side, then my left. I've got a process for that. So what you have to do, or what I do, is I loosen the belt when I go to bed, and I just rotate it to the opposite hip. And then when I roll over, I rotate it back. I don't even know I'm doing it now. So
Not too hard.
It's not too difficult.
Okay. Stacy has something to say.
For those of you who are caregivers, there's an alarm that goes off when you've got an hour left of medication, and it's really annoying. So if you want to sleep more, you just start punching them, and then they'll get up and they'll turn off their alarm or whatever. But it's really nice because you can't mess up. I was really scared when we were doing it that I would mess up and I'd give them too much medication or too little, or I'd do it wrong. The machine is dummy-proof for people like me who want to speed through stuff. And it tells you exactly, you need to fill it right now, you need to prime it right now, this is how you need to turn it on or turn it off. So it's so much more simple than you would think it would be.
Good. And then, have you had any trouble with the skin? Have you had redness, painful spots, anything like that?
A couple times we've had redness. One time, because I wasn't paying attention, I actually caught the cannula on the edge of my desk and stepped back, and the cannula stayed on the desk, so that was fun. But I haven't really, fortunately, experienced any of the little nodules
Good, yeah.
or anything like that. I mean, the big thing is you got to pay attention, and we'll put it in. If it doesn't feel right, take it out right away. I've only done this about 70, 75 times, so we're just over 2 months. But that is the one thing. If you just listen to what your body's saying and it's uncomfortable, then don't fight it. Just remove it, and then find a different place.
Perfect. So I just want each of you to give me one little tidbit to share with people how much it's changed your life.
I was on the roller coaster, and I was very dyskinetic on the up and on the down. So my on times were very small and shrinking. And when I started this pump, it was unbelievable. It was life-changing. I mean, for me. And I'll just tell you, my grandson is just over 1 year old, and he's been put on my lap many times. But getting this pump, I picked him up for the first time about 3 weeks ago. So that's all for me.
Awesome.
It's hard not to get emotional when the person you love is going through so much. And this pump is, to us, it's been a miracle. That's the only way I can put it. I just want to share this story that is probably the reason we're here.
Yep.
When you have the pump put on, they send you out to lunch, and they say come back in a couple hours. And we went out to lunch, we came back, and we were walking through the parking lot. Nuts. And Jim reached out and held my hand, and we walked holding hands. We haven't been able to hold hands and walk for 5 years because his hands were so stiff to his side. So for us, the little bits of life that you miss out on, Jim was diagnosed at 37, and it's been 20 years now, and we didn't realize how many little pieces of life we were losing. And this pump for us right now has given that back. And I know it's not forever, but at least for right now, we are very, very blessed that this medication has come at this time in our life.
I want to say thank you to both of you for coming, because I feel like it's so much better for all of you to hear from someone who's actually done it than me just standing here saying, I think it'll work for you. So they made me cry in my visit with them, which is why I asked them to come make you all cry, because it's really, really important to see that piece of life, those pieces of life that we can give back. And so if anybody is interested in this continuous therapy, it's really, really a game changer for many of my patients. And ask your doctor about them, because it can be done, you can get access to it. So I think that was a great way to end our Empower You this year, was with this great story. And I hope you all enjoyed the day, and I hope you learned something new and something you can take to your doctors and say, hey, can I try this? Because I learned about it at Empower You. So thanks all of you, and thank you all for staying. I was the last one, and it's tough because I'm tired too. So thank you all for staying and listening.